gone across, it's involving more than one area.
Yes, sir. It's
त्याच्यात ते दिसणार.
Actually,
बघ.
transfer section.
so it's involving only one compartment.
It is difficult to say considering the previous surgery has taken place, but it looks like that it is going from
Posterior.
mainly
Posterolateral.
posterior, but going into lateral compartment.
Posterolateral.
So basically, when we do MRI, there are different sequences we take. So that's a T1 weighted, T2 weighted. We also take stir or the inversion recovery, what today Dr. Chadha was saying. So depending upon what we want to see, whenever there is a tumorous lesion, whenever we want to see, then after doing the fat saturated, we want to see how it is, whether there is any infection or whether there is any tumorous involvement of the bone or the decortication. Now how the vessels are looking, that we need to see. For that we will request for stir sequence when we are suspecting something tumorous lesion.
I think one has to know a little bit of MRI because two things like what he said, these are the basic things you have to know about MRI. But that's what we asked again. The first thing, whenever there is a tumor case or even sometimes an infection, MRI is asked and they will ask you for T1, T2 image, all those things are going to be asked. You don't have to be really an expert, but many things are expected.
So what will you do now?
I confirm continuing the biopsy.
Looking at biopsy report, right? Biopsy
You can also say that if the patient has been operated already, it is very difficult to know. That you can always.
No, but always when you have the history that after a surgery the tumor has increased in size, which is what he said, it is already extra compartment. So we are talking of a tumor not less than 2 B on any king stage. That means high grade and extra compartment. The only thing that you need to know, does she have mets? So HRCT or a nuclear scan will tell you whether metastasis is already happened. If the stage is already metastatic, we are talking only of palliative surgery.
They've done in Sata Memorial on the 4th of October. They given as left arm soft tissue structure, then biopsy has been done, granulomatous inflammation, negative for malignancy. And as far as we mentioned,
This can be
sarcoidosis needs exclusion.
Now, if you give a diagnosis of sarcoid from beginning, you have seen everything. Examiner, you can give a diagnosis of sarcoid. So fine. So after all this, we come to conclusion. After biopsy, there is not a tumor. It is some inflammation. Treated medically should be all right. That's why it's very important to get all the investigations and the proper biopsy before treating. The first plan was before X-ray excision. I'm not a medical expert. So sarcoid को कैसा treat करता है I don't know. मालूम है?
basically sarcoidosis is tuberculosis का virus.
So essentially, tumor case approach has to be one. Malignant tumor and a benign on clinical grounds you should be able to mix.
Yeah, in fact, even if your diagnosis is wrong, if you reason it out and you say that this is the thing, then investigations can show you something else.
This is
You can get a positive mark for your diagnosis.
100% pass.
You can
go systematically.
Yeah, you can talk about this and argue it out like a tumor.
If you say sarcoid, you are failing.
Yeah, in fact, when you diagnose with a sarcoid, the correct diagnosis will fail you.
Okay, so benign versus malignant, you should know the clinical differences. Well circumscribed tumor, which is slowly growing, which is eccentric. Expansile are cysts, and the only eccentric expansile tumor which is soft and painful is an aneurysmal bone cyst. A simple bone cyst will never come to you unless there is pathological fracture. commonest tumor you will get in exam is the exostosis. Firm, hard, painless tumor. You should know which are the areas or which are the cases which need intervention and which cases you can just observe. Indications for surgery are sudden increase in size or pain, blocking a joint, pressing on a nerve, or fracture at the base. Most common conditions. Otherwise, exostosis is the common tumor you get. Second most common tumor you get in examination is going to be a malignant osteosarcoma or a EB. Lower end femur is what we usually get in exam. And your approach has to be similar. This is a malignant tumor of lower end of femur arising from the metaphysiodiaphysial area, primarily metaphysial. I say it is malignant because rapid increase in size, night pain, variegated consistency, shiny skin, dilated veins. What will you do? X-ray first, which will show onion peel or sunburst appearance in the areas of destruction, and get an MRI done, a bone scan done, X-ray chest, and then I will do biopsy. Stage the tumor and then decide whether limb salvage can be done, whether it is amenable to radiotherapy, whether it is amenable to chemo. Few cycles of chemo, shrink the tumor, do limb salvage, do prosthesis, intercalary graft or allograft. Prognosis is guided, 60% survival at 5 years for any tumor, roughly. Tata memorial का figures मालूम है, but international figures usually Ewing's fibro, chondrosarcoma has got longer survivorship, better ML. There is no chemotherapy, there is no radiotherapy for cartilage tumor. Always surgery. Ewing's radiosensitive. Osteo chemotherapy shrink, maybe limb salvage if you have the expertise. Best option radical amputation. ठीक है?
We have one case which nobody has assessed.
Very good. Now tell me, what is the difference between pseudoarthrosis and non-issue?
Pseudoarthrosis is a false joint formed which has a developed articular surface, fibrocartilage and articular
Synovial membrane and lot of fluid and loose bodies. This pseudoarthrosis is non-issue.
both can be painless. This can, I don't know the history, but this can be not.
Just observe, no history is required. I'm telling you, look at the patient, look at the stage, look at the, just look and tell us what it is. Tell her to do some movement.
Doesn't it look like a second elbow, accessory elbow?
What is this? There is a scar. Okay, what is this?
Very good cases.
One scar, two scars. What kind of scars do you think are these? Huh? Somebody has put nail. So somebody has done enders probably. That is the only answer. Open reduction. Unfortunately, she has no risk. कितना साल हो गया? 5वां साल. So, no diagnosis. You don't need history. You keep your eyes, ears, and brain open. X-ray. Number of cases and presenting them. घर पे बैठ के किताब पढ़ के नहीं होता. Present more cases.
It's a plain X-ray of humerus epilateral view showing at the mid shaft level of the humerus there is irregular margins. At the
Fracture है बोल पहले.
fracture at the shaft humerus middle one third showing regular margins at the end, which is displaced fracture. Then there is general osteopenia also seen.
What do you want to do?
What kind of nominee is this?
So atrophic non-union.
Yeah, synovial pseudarthrosis with atrophic type of non-union.
Non-union.
What do you want to do?
So I would like to, I just want a stable, I just want to debride, I just want to open it, freshen the edges.
You want to operate as a man?
I want to operate it. And
I would like to
fix
offer
it.
a surgical treatment.
Open reduction
Step
internal
by
fixation with the bone grafting.
open reduction, internal fixation.
We
with
would like
bone
to
graft.
ask her what is her occupation, or what is her
What is
requirement
her
of
disability?
that, what is her disability, whether she has any problem.
She
And
five-
then you will decide na, whether she
five
five
years-
I
years.
want to consult with the patient first. And if she is presently disabled with the deformity she is having, I would like to operate as
You
a
can operate, you can do fantastic job, but whether she wants it,
Yeah.
she might be happy with this.
She might just ask you that I don't want this car, I'm okay with this.
Ask her now.
The 5 years she hasn't had any
Now
problem.
you ask what is the
Can
problem.
you ask her?
She said, I have
What
got
is
this
the problem?
cosmetic
What she-
deformity on this car.
तकलीफ क्या है? कुछ नहीं।
हाँ, एक तो इधर आके
जैसे जो हाथ में तकलीफ है, उससे आपको कोई काम करने में तकलीफ होता है? कोई भी काम हाथ ऊपर उठता है? पर फिर कोशिश करने की जरूरी नहीं है, आपको
Doctor
लगता है हाथ ऊपर उठना चाहिए।
Ask her why she has come for treatment.
हाँ? नहीं आता। अभी अभी हॉस्पिटल में आप इसलिए वही आपको कोशिश पर उसका हाथ ऊपर जाना चाहिए ऐसे लगता है। She wants to lift her hand. She is having no complaints as a pain as such, but she is
Inability to abduct without a distal fragment falling. Discontinuity check.
It's
No, it is
unstable.
painless. It's unstable.
ऑपरेशन करेंगे तो ऊपर हो जाएगा, कर देगा ऑपरेशन।
वजन उठाए जब तक then women are tolerant. They can do anything.
Yeah, so
So now you are justified in offering her
surgery.
in the form of
Bone reduction, internal fixation with bone graft.
approach.
So middle one third, so we would like to go with the it's slightly on the lower side also. I would like to go with the posterior approach. Dissect the nerve and retract it.
Already has a scar on the posterior aspect.
Or it's better to go through that scar only.
Hoping that you know where the aspect is. Will you use regular plate or locked plate?
Considering the osteopenia and I would like to use a lock.
Why?
Lock.
Why?
इधर काम कर।
Why locked plate? Why?
It's osteoporotic bone, so I would like to use a locking plates.
Disuse osteopenia.
Disuse
Tell me the steps of operation.
So after anesthesia, I would like to keep the patient in a lateral position with a pillow beneath it or a plate. The stable is provided
Where are you
that
working?
supporting. Huh?
Where are you working?
Dinath Mangeshkar, Pune.
They have everything.
Yeah. So I would like to then, after painting, draping, I would like to take a midline incision posteriorly after each subcutaneous plane, and I would like to go through the triceps itself, triceps splitting approach. I would like to dissect the radial now. I will dissect the radial now from above to below and retract it with the help of infant feeding tube. Then I will expose the bone, will freshen the bone ends, I will remove the whatever synovial tissue is
Will
there.
you shorten?
Yeah, I need to cut the ends to make it freshen ends and bleeding ends. So after that, I will approximate the edges and will put a plate, and sideways I will put a bone graft. I need to take it from iliac crest.
Post-op protocol?
Post-op protocol, I will just give a arm sling, not more than, and start mobilizing immediately. On day 3, after drain removal, I will start mobilizing.
How will you protect area now? What care you will take?
I will dissect thoroughly and will put with the help of infant feeding.
Tell us the course of the radial nerve with the radial.
Sir, radial nerve is a branch from the posterior part of the brachial plexus. Arising from the brachial plexus,
Between which head it runs?
it runs between the long head of triceps and lateral head of triceps initially. Afterwards, it is in between the lateral head and medial head of the triceps.
Initially, you take the long head away and
Okay.
then split.
Split in between lateral head and long head of the triceps.
And where do you trace proximally the radial nerve? So your incision should go to the posterior border of the deltoid insertion. If you take a small incision and don't expose the deltoid, you struggle with finding the nerve. Always take a longer incision from insertion of deltoid, just where the deltoid inserts. See, it just comes below that. Crosses over from medial to lateral. From there you can just palpate and trace it, and then one head goes away, then split the bone. Okay. One quick question.
Ulnar osteotomy, ulnar head osteotomy. That is a Campbell's incision.
Can you do interlocking nail for us?
We can do, but we need to do a bone graft, so we need to open the fracture site. We need to freshen it, so it's better to go for a plain rather than a. Aim is to have a union, not
You
to
can
have a
inject
fixation.
bone marrow. When you read, it will open up. There will be bleeding, there will be marrow, BMP, which is going to be atrophic.
But again, close making is very difficult in this case.
आराम से
There is a need for a stable fixation.